All right, let's get started. So good morning and good afternoon again, and thank you for joining us today. My name is Allison Jones, and I'm the Director of Marketing at EMD, and I'll be your host for today's presentation. Welcome to our latest Practice Partner Lunch and Learn. Today, our focus will be on ICD-10 coding and the end of the grace period that will require us to be more specific with our coding moving forward. But before I pass it over to Susie to get started, we have some general housekeeping items to go over. Today's session is being recorded and will be made available to participants after the event. So keep an eye out. You'll receive an email that will have a link to the recording of the session, as well as a link to download the PDF of the slides that we're going to walk through today. And if you have folks that are in your office that were not able to join us, or for VARs that are on the call, if you have customers that weren't able to join us, we encourage you to share those emails and forward them on so folks have access to those links and can take advantage of this education that we're going to go through today. All attending lines are in listen-only mode. We are expecting to have time at the end of the presentation for questions. So we do encourage you to submit your questions at any time, and you can do that using the Q&A tab in the WebEx tool, as well as the chat tool, and we'll be checking both of those, and we'll address your questions at the end of the session. On the screen, you should be able to see the slides for today's discussion. If you want to enlarge the screen, you can click on the double arrows in the upper right-hand corner of the viewing screen, and that will give you a full screen view. That really does it for my housekeeping notes. So now it's time to start talking about ICD-10. And as I mentioned, we have Susie here to walk us through this presentation. For those of you who haven't joined us, a little background on Susie. She began her career in healthcare over 14 years ago as a medical billing specialist, and since then has acquired a wealth of knowledge as a billing manager, practice management trainer, and an EHR trainer, and she's currently an EHR implementation consultant at EMD with extensive experience on our Practice Partner product. So we're looking forward to having her walk us through this presentation and telling us a little bit more about what to expect with the end of the ICD-10 grace period. So without further ado, I'm going to go ahead and pass it over to Susie, and she's going to kick us off for this presentation. Susie?
Thank you. Good afternoon, everybody. Thank you for joining. I'm going to go ahead and walk through and get going on this session today. And as always, today's webinar is specific to the subject of ICD-10 specificity, flexibilities, hard word to put in one, and on October 1st, 2016, just right around the corner. And as Elson said, we should have about 15 minutes afterwards to talk about questions and answers pertaining to this presentation. Also in this one is I just wanted to make sure examples of coding scenarios are examples only in this presentation. The documentation must be present to support all coding, and what I've used in this presentation is examples for training purposes only. Questions and not related to this session can always be emailed to the Meaningful Use email address listed below, and we'll get back to you as soon as we can on those. Thank you for attending. So today's discussion, we're going to talk about the ICD-10 coding, the flexibilities ending on October 1st, and what this means to all of us, updates with the HLI system, configuration options in special features to insert problems by the ICD-10 description versus the provider-friendly text, talk a little bit about problem list management, and some tips on searching the HLI system, as well as then some template options to help with coding selections options in this presentation. So basically the flexibility, as most of us know, I mean, a year ago today we were all getting ready for this big change, and it actually went off fairly well, but Medicare did come back and gave us a year of flexibility, meaning that you could still go ahead and code codes in the family of the related treatment, but they weren't going to be real picky about the specificity of the codes. And more or less, the whole purpose of that was so that the Medicare contractors performing medical reviews on the claims would not actually deny claims just for the specificity to the ICD-10 as long as there was no evidence of fraud. So that's just a little background as to why they gave it to us and why we had it for the whole year. But what does this mean to us now and the grace period coming to an end with the CMS? Well, basically a lot of the majority of the commercial carriers really didn't offer that flexibility. So some of you may have been dealing with it all along with the year, just certain codes being changed, or maybe not had too many problems at all. But this is really specific to CMS and in general as far as kind of bringing that to a stop. Some commercial carriers might have allowed it, but not all. So the end of the grace period also doesn't mean that you're not allowed to use unspecified codes. Those codes still exist, but they should be warranted before you use them. So if you're in a habit of always doing it, which when we lived in the ICD-9 world, it was pretty huge on using unspecified codes because we could. But now with PEN, they're going to start narrowing that down and to be able to get away from using the unspecified codes. And CMS does encourage providers to avoid using those codes whenever the documentation supports a more detailed code. The encounters, as usual, even within the ICD-9 world, should always be coded to the level of certainty known for that encounter. So there again, it kind of, I mean, if you've got more information in that encounter, you should be coding to a different level versus choosing a code that you're used to using all the time and worked previous. So you want to kind of start getting in the habit of looking a little more specific as what it is that is being chosen. And then last on that is that with the coding changes, there's going to be updating of quick text and templates of current certain codes if some of these codes have changed, because we also are in, as October 1st rolls around, is the new CMS codes that are being released. And there's going to be an additional 1,943 codes with 422 revisions in this. So a lot of them is just a short example here, and on the back of the slide there is a link to the changes in the codes. But you can see just right from the very top here is that a lot of the codes are going from the 4-digit code up to the 5-digit code. So in that release that they came out to it, you'll see a lot of adds. Those would be codes that are being added to it, some deletes that will be removed, and then there will be some revised codes. And with the revised codes, the code may still exist, but there may be a little bit of different wording on it and so forth. But if you are using dot codes and have a lot of these codes embedded into your templates, then it is important that you go through your quick text and other areas where those might be added on the note that everybody's been used to using and get those updated for the codes that are pertaining to what you use, so that those will go out correctly after October 1st. So with the changes coming on, I mean, that's going to be ongoing as we come through there, but I wanted to kind of address some things in the problem list and the mechanics of the problem list, because as we even grow into ICD-10, which we've had a year to kind of get used to it, and it went fairly uneventful at this point, it's still always a good idea to always be in the process of improving on your documentation, improving on the data flow of your system, as well as the fact that with this particular product, we push and pull problems with dot codes back and forth from that problem list, which is kind of like a hub that pushes all the way down to the EEF, as well as now with our interoperability and pushing down to the CCDA that's going out to other sites, as well as the clinical encounters. And so with the problem list, by kind of understanding the mechanics, might help you improve on that, as well as putting output information that goes out to others that for years nobody really had to look at. And so the problem list could get a little messy in there as we moved on. So with the mechanics of the problem list, the major problem by design, it would not duplicate a problem. And in ICD-9, this process worked well because it actually looks at the description. So that information would push and pull, and your problem list, you wouldn't have 50 million different, hypertension type codes in there, whereas in the diagnosis code, it'll do it by date. When ICD-10 came along, there's so many variables of the diagnosis codes, it will duplicate the entry if that description is different. And so you've probably already experienced that where with the provider text the way they would look up a code, and then if they pushed it down to the problem list, it didn't match up with something else that was already in there, and then it would duplicate into that major problem list, where prior to that we were used to it not having to do that all the time. And we've made a few changes on that we'll talk about here in just a minute that can improve on that. The other problems in diagnosis tabs, those will add the diagnosis code by the date when they're pushed down to it, and then it just accumulates in there. It doesn't update the diagnosis or the other problem list like the major problem would if it matches up to it. So those will go ahead and be added into it as it goes on, and it's focused by date. And then the risk and hospitalization tabs, they can duplicate on that, how you're pushing them. And in the last session that we had, I did talk about the new feature that you can go in through the ppart.ini file and set this up where you don't actually have to push diagnosis codes into the risk or hospitalization tabs if you choose not to, and it makes it kind of easy to be able to push information down in there that can be inserted back into your notes without associating them to a diagnosis code at all. So you have that option as well. Problems then can be inserted to the progress note from the major problems and other problems of diagnosis. However, by inserting, doing the insert for a diagnosis, or if you're using the other problem list, most of us don't do that because there's a lot of information in there and we'll have lists forever going on to it. But when it comes to the major problem list, a lot of the ongoing practice is to insert major problems such as chronic illnesses and different information like that will go ahead and pull back in, possibly under your past medical history and so forth as it comes on. And so with that ICD-10 coming along and then the possibility of duplicating different information on that may still mean the same, it's added to more things coming back into the note. So we'll talk about that in the next slide as to ways that you can kind of work on getting some of that cleaned up so that it looks more, it's easier to go ahead and manage and then move it back into your templates if this is what you choose to do. The other thing is the use of the Shift F8 or the insert button in the toolbar allows to bring in problems into your progress note at that time, and those are very helpful to be able to bring in existing problems back into the progress note, and then you can push them back down for the encounter to go back out to it. And this will allow, by pushing and pulling right from those options, to keep from duplicating information in the major problem list and only updating it to the date last versus continuously adding extra information as it goes on. The problem list also allows for updating, documenting life cycle and making inactive codes, allowing for management of. And so not a lot of practices that in my experience that I see that physically goes into the problem list and changes things and moves things from one tab to the other. But there are codes that you have that option to be able to go in and make codes with a life cycle on them, make them inactive or active and so forth, that can be helpful for managing the problem list if it's something that works well into the workflow. And I've given you some options on that as well. But overall, like in a good medical record, one of the things that, when you look in auditing-wise as well, is that if I came in for a visit and I had a diagnosis and then on my follow-up visit, they want to see some kind of a, documentation that shows what happened with that follow-up visit and if that problem has now been resolved or the life cycle of it. And so by utilizing some of the options we have in partner with codes, you do have the ability that you could use that from the note and push down as well as keep it documented. So a while back, in special features, we did release a patch that allowed you to change the way problems are inserted into the note or brought back into the problem list as well. And it's found under the Special Records 5 in Special Features. There's a configuration in there that you can change the way the information pushes down. By default, it comes in as use provider-friendly term, which would be how they're searching when they go to search the HLI system, whatever information they put on that, and then they choose it. That's how it was inserting previously to the change on that, and it still will do if you have that use provider-friendly term box checked. You can also go in and change this so that you can come back in and change it to use the ICD-10 code description for the notes and problems, which basically does a couple things. It makes it nicer when you've got it inside your note because it pulls, like you can see right here, is essential primary hypertension is what I pulled from the HLI, and then that's the ICD-10 description. that would pull onto my note as well as push down to the problem list. So you can see by utilizing that option, then as I go ahead and keep using that code or inserting it back and forth from the major problem list, it's only going to update my problem list in the major problem. It's not going to continually add different text in there, whereas you can see by not having it on, and which a lot of you may still have that on, is that by adding notes information in there and having the provider-friendly text term, if I search by, HTN or hypertension, this is how it's going to push back and forth, back and down to my problem list and so forth. So the difference is turning that on would help manage that problem list as well as kind of change the way things are moving into it and so forth. So that's found in Special Features Records 5, and it's just by turning on the other toggle. It doesn't, you won't even really, the only difference that anybody would see is when they go to insert a problem down into the note, it's just going to bring in the ICD-10 description that's in the HLI system versus what it is that they chose and typed into the search window. I like it myself better than the text, but again, it's your option as to being able to leave it on or not. If you haven't made any changes right now, it's defaulting to the original setting as the provider-friendly text. So this is just an example on the major problem list, is if I'm inserting using different text information that comes on, you can see where it pushes and pulls back in the problem list, and I could have essentially the same diagnosis code in here twice as it goes on, which is going to document and change the dates for me, whereas if I'm utilizing the new setting, and then and as well as being able to use the Shift F8 information to bring chronic illnesses back in as well, it would prevent from putting those back in, back and forth and duplicating it up. Because you can see over to the right here where it says the date last, if the code originally, that's the original date's going to be when it was inserted in the problem list, and then the date last is the last time it was updated. So that information is just going to go ahead and update right there into the problem list as used. Now keep in mind with the ICD-10 and the variables in that, if I choose a ICD-10 code that's got a different description, it would go ahead and multiply back into that major problem list because it's matching the descriptions, not so much as the code. And hypertension is probably one that causes more culprit than anything, and because we have one code for the different options as well as it goes on to it. But by changing that, then it allows that to go ahead and push and pull back and forth if they're choosing that ongoing code and forward moving. So again, with when I talk about using the Shift F8, if you haven't ever used that when they're inside of a progress note or even the history note, you can hit Shift F8 on the keyboard, and it actually brings up this window here, which is your problem list. And with the ability to bring into it, you can see that they can choose codes from the major problem, other problem, or the diagnosis. And then down at the bottom, you can insert them back in as either a major problem, a diagnosis, or you can actually bring them in without a dot code at all, which the purpose with that would be is if you're going to bring them in, but you don't want them to push back into the problem list ongoing. So that information is how that pulls. This is the same window that you see if you go up to the task and insert problems right back into the problem list as well. So it's just information that comes in, and then it's going to go ahead and update that information. You can also use from the Shift F8 when it comes in, holding the Shift button down, you can choose multiple codes, and it's going to go ahead and insert back into your note. So this option is available to be able to use it, and there again, if the problem list is well maintained, it makes it easy for providers to go ahead and use that and bring problems back and forth or the same codes back in. You know, another thing, when you look at your injury type codes now with ICD-10 and they push down to it, I may be being seen for, you know, the left leg type of fracture and all that kind of information that goes into it. So if you're utilizing it, it makes it easier for them to bring that back in as well and to be able to utilize that versus having to go in and search for it every time and so forth to bring it back in. The other thing to keep in mind with the problem list is that they push out to the CCDAs on the clinical summary or the when you send things over to the direct messaging and into a transfer of care. So with problems listing out coming on that, it brings in all the problems with their active, inactive information that comes onto it. And so you can go in there before you send it and remove some of those, but they are available in there. So it's just another reason to kind of keep the problem list cleaned up a little bit, so when information pulls over and you have other people seeing it, that they can make sense of it, and there's not a lot of stuff in there that shouldn't be or they don't want to see. So with the major the problem list, the managing of, these are some dot code examples, and you have it, major problem, the other problem, and the diagnosis from the 2 to the 6 options that you can use inside of your templates. So right now you may just use like a .mp to pull things over. These could be used on that, and then you can bring the codes in. Obviously, you'd want to bring that information in, and then you have different formatting in here that, according to the dot code, that can push and pull data back and forth. You can also pull information as well from other parts of the chart into it that'll automatically populate using letter codes. And then you have your choice of being a life cycle that would allow them to go in and update those as being worsening, better, resolved, and so forth as they come through. And so these options are all found in the help files that you can populate in there if it's something that you can use. And again, it doesn't pertain to all practices, but there's certain templates or something that may be beneficial to use this option in, and then it's going to allow you to kind of narrow those down and then allow to being able to manage the problem list a little bit better and then push and pull data to a more specific reasoning. So this is just information about the dot code and the additional data and the problem. What I found is using those specific dot codes are best served in quick text or hard code on the note. I mean, you're never going to have somebody remember to do all of that functionality, by hand information, or leaving it wide open, because they're going to have to choose the exact code that matches the ICD-10 and so forth that it comes in. So if this is an option that you go ahead and choose, or you want to update some of these, they're best served as being inside of a quick text to be able to update them as well, to be able to utilize them and ongoing as this. So it just allows them to open this up and push and pull the way they want to and document. As I said earlier, is the problem list does pull onto the CCDAs, and this is how information that pulls into it. You can see the problem status right over there as to pulling from the problem list. And so, as we keep moving into that era where we're going to be more sending data out of the system, one EHR to another, it does get very important to have problem lists updated and clean, because this is what your patients are seeing as well as other offices. So it's just an idea is to know what you're seeing in here, and then understanding that those statuses do come up there and ongoing and pulling right from the problem list. So there's more than just, the EEF and that kind of stuff that pulls from the problem list in general. So as we have been going in, and since we updated to version 11 in the HLI system, there's a lot of things going on with that I know I've got a lot of responses back from people that it's, I think a lot of times when they go in to search for it, they're thinking that if they just put in a certain word or phrase, what comes up to it is going to be the first choice. And by human nature, I think a lot of people choose the first choice, and then the code goes down and on we go, and then it needs to be changed as it gets all the way over to billing. And so I just wanted to kind of spend a couple minutes on this and talk about ICD-10 and then the searching on that as it goes on. Basically, it's a gem, and it pulls from the CMS, and it's a cross-reference, and so it's associated with your SNOMED, your ICD-9, your ICD-10, and then phrases. Provider-friendly text means phrases that I put into that search. And so when you search by something very vague, this is why you may get something with a result of, 46 results going on to that, and the first result may not be the one that is what should be used. However, a lot of times when we bring that up, we're assuming that the first choice comes up and that's what we're going to get, and it pushes down. And it's not really specific to the encounter of what I should be using to begin with. So the first thing to understand about ICD-10 is that there's a lot of different things associated with it. And when you think about searching in the ICD-10 or the HLI system, what is associated with those codes are the type, certain findings, location, caused by, contributing factors associated with, severity, and episode. So those are just different informations that are associated with the code. And that's a lot of stuff in there, but what the point is that if I, with this next example, if I am looking for a migraine and I just type in the migraine, then that means that I'm going to get a large search, which you'll see on the next slide. But with ICD-10, in the terms of a migraine, there's certain things that are associated with that now, like intractable, treatment-resistant, refractory, poorly controlled, information like this. The type of migraine is now important in ICD-10 where it used to not be so much. In ICD-9, is it chronic? Is it persistent? Is it due to a menstrual time period or abdominal? Because each one of those codes have different meanings, and then at this point when they're going to go ahead and choose that diagnosis code, the documentation would have already been pointed towards some of that to be able to go to it. The other thing with a migraine is that you've got the symptoms that signal to either a classic that's got aura or without aura is a common migraine. So as that's just information that with the ICD-10 that's associated with back into the HLI and wording that's used. So like I said earlier, is if I were to come in and I wanted to, my intent was to go ahead and find a diagnosis code that is a menstrual migraine intractable with migrainosis, then if I just typed in the word migraine, which was pretty common as what we did in ICD-9, you can see that my results come back and I get 42 results, but my first result is an abdominal migraine, which has nothing to do with a menstrual migraine and a completely different diagnosis code. But because I'm being very generic in my search, it's bringing up the first thing and it begins with an A, information that goes on. So as you're searching in that, when they get down to the assessment part of it, what needs to be in their mind is when I go to search for it, if I can even come up with the type and narrow down that search, it's going to make my search much less laborious to be able to go through, and I'm going to get more to what it is that I'm actually looking for. So with this next slide is the tips in that. If I type in more specific to my migraine at this point, just by adding just different phrases on that, it narrows the search down to an easier choice. It's still not the very top one, but the results are over to the right, and I can move that down, or if I even add another word down to it, it even narrows it further down to it. At this point, when they get to the assessment part of their note, they really, a lot of this information, they already know that. They know where it's at, and what phrase is in there, it's just a matter of putting the phrase into the information. If it's too much and when they go to search for it, it may be something that when you look at the template in Practice Partner right now under the migraine or the new onset of migraine, those diagnosis codes are in there, information already onto it. So as long as they're updated on that, it might be easier for them to go there to the text versus trying to do the HLI system. But there again, even if you're setting up the quick text, understanding what it is that you want to associate that diagnosis code with is going to go ahead and make it much easier to go and follow through on. So again, it's those phrases that the HLI is looking at and how it's best described on that with ICD-10 that's going to narrow the search much better than being very generic with it or not putting everything involved with it that's going to make it harder to find the exact diagnosis code that is needed. So these are just a couple of other examples I just threw in there, like abdominal pain, the type is pain, acute, and so forth, information coming on, findings, and that kind of information that goes on. So when they're searching, again, when they get down to the assessment side, when I say them or all of us, whoever's doing it, is that if I think about where they are, where they came in and what kind of findings I did find throughout the encounter, by finding the right diagnosis code down there by using it, it's going to go ahead and make the HLI system narrow down to the search much better than what it is by being very generic, and then ultimately being able to come to the right code that I'm going to go ahead and associate with the encounter. So with the template information that goes on, I mean, a lot of the notes that come into Partner, I've gone through a lot of them, even looking at documentation. as ICD-10 comes on, and the canned templates are very good as far as supporting documentation. But Partner gives us a lot of ways to be able to utilize data within those by having the ability to use quick text and narrow things down that might give you other options to be able to use and to get more specific in the coding on different types and make it easier for providers as they get down to the assessment part of it. And one of them is that, in this example here, is that you can actually, I mean, this is like a hard-coded with a .dx information, but would be something like for a wounded leg. When you use the HLI system and you type in open wound leg, then you get a ton of different results that I have to go back and search. Whereas if you had something set up in the template that is associated with your type and your location and so forth, just like what I have here, when they choose this code, you can see here below is that I've chose laceration and with foreign body, and it's the left ankle, and it's the initial visit. When they go ahead and when they go to save this note, it's going to pop up with this little box that says, hey, wait a minute, this diagnosis code doesn't look so right. Once they hit lookup, because it's associated with the data that you've put up in here, it actually is going to go ahead and launch the HLI system, and it really is going to go real, I mean, as long as you've got the type information on there, it'll bring right up to that first or second layer that they can go ahead and choose that code into it. The only thing on there they'd have to understand is that when they go to save the note, this is what's going to happen, and then they could go ahead and click on the code. But by utilizing ICD-10 rules and guides and setting up information like this, then it's going to make it narrow down. As I said, not every template would work this way and not every situation, but I found like in the injury world type stuff, this is a good alternative to use because there is so many different things to wounds and all that changes that come in with ICD-10 to be specific versus having them try to go in and find, you know, a wound to the leg. This narrows it down. They've got it documented by the time they go down to it, and then the HLI is going to go ahead and populate up, and then they can choose their code, click OK, and it's going to go ahead and move on, and they'll be able to close that note on, and then they've just got the code that they really want to be more specific with. The other thing is with using structural data in Practice Partner and clinical elements, vitals, and all that information that comes into the system ongoing right during that encounter. Because by utilizing some of that structural data, it also is going to be able to help trigger different types of codes needed on this. So like in your vitals, smoking is in there for meaningful use already. And this conditional logic, it'd be something that you could, you know, push down in there so that they need to, I mean, if the person is smoking and they get it documented on there, again, they could push something like this, and it's going to go ahead and it would pull in the smoking code in here right down to the bottom. So there's just information on that. And as I said earlier, again, when you use these, make sure that my advice would be if you were going to sit down and use some of this information that you sit down with people who really understand the whole idea about the coding as well as a physician champion so that they can see what best is going to work and then their workflow to be able to come through here. Another thing is like the use of clinical elements, and this would be in the form of asthma, and you've got your the PFT ratings that come in. The template already has these in there, but they're not set up as clinical elements, but you could set that up and push it down, and so your ratings, basically on the ratings of what comes in as to that test for that day, could be pushed into clinical elements, and then when it pulls into the note, different percentages of what that patient scores on that is what determines whether that is a persistent, mild information that goes on to it. So just different information like this would help go ahead and narrow that down because it's data that is in the system. You've got it pulling into the system ongoing for that encounter, and so the documentation is there to help support that. The same thing down in here is another step on here would be, you know, the difference with severe persistent asthma, but with the status of asthmaticus, because with that, I have severe asthma, but there's other vital signs that a provider would look at to see whether it's going to be, you know, with a status or not. So you could use extra logic in there, pulling from the vital information that would be able to allow to kind of narrow these codes down. information that goes onto it. And then obviously, if you have logic into it, a template, and that patient doesn't have some of those elements that you've written into it, you wouldn't see the logic anyway. It wouldn't come up. So it's just a way to go ahead and clarify it down and information that comes on. So these are just examples of being able to go in and utilize the functionality in the system to be able to help with getting the specific information into it, utilizing the documentation that's been pulled into the system via vitals or the use of clinical elements and so forth. This is just information that I showed you, what things were pulled through and information that goes on. So if it's vitals, I mean, it just needs to be in structural data how you're pulling that information in. But it's just basically what I pushed in and pulled in information that shows you how that came to that conclusion. I just put one diagnosis code on there. You could be very specific and add different options because, in the end, it's really that provider's choice as to what diagnosis code he uses. So you could actually add quick text in there as well that, if this, then that, and then it would only bring up certain choices on them to use. Again, you have to think about your site and am I using specific templates for specific problems, or do I have one template for all problems? That would definitely have an effect over how it is that you utilize any kind of conditional logic into a template. The other thing that you can use is structured lab data, which I've given you an example here as to how that goes on to it. And there again, with certain types of labs that may indicate or may not. In this particular one, certain levels of the GFR will indicate some chronic kidney disease, but there could be other elements that you would want to go ahead and add in there. And that's why I guess, again, if you're going to utilize something like this, you'd want to make sure that you spoke to whoever is going to be using them to make sure that you had all the different levels that you have. But labs are great structural data if you have an interface coming into it because that information is there. And that, again, is a lot of times what comes back from those tests may help with being able to give a true assessment to a situation that's going on with a patient and then the levels of what are the guidelines as to how things are being associated with those diagnoses. So this is just information as using lab structural data to be able to come in and tie it into different procedures. So the other kind of thing is using the structural data that Partner really has a good hold on and given us as users and people that build these templates a lot of flexibility is the ability to use these, and then with the choice of dot codes and insert codes and letter codes to be able to push and pull data back and forth. So with this, the other thing is what I call setting up triggers. And as we start moving into the situation where we're needing to pull more and more data out of these systems one way or another, and to be able to separate these, the setting up of like clinical elements of what you have like this is kind of, more of a population type based information on that. But by utilizing this information and setting it up in your templates, it's going to give you a lot of flexibility to do a lot of different things with it, not only even reporting. But with this type of stuff here, if you set things up, you can, associate patients with a certain type of insurance, and then down here of even diseases, which we know we can pull patient, inquiry reports out of the system, but sometimes it's not as easy as it sounds and it takes a while. But by utilizing this kind of concept in the system on an everyday workflow, it's allowing for, as the notes go through, pushing data down into the clinical element area and then giving you the ability to actually pull data back out of that much easier than trying to rely on different codes and so forth. With ICD-10, when we will try to pull a list of diagnosis codes, we've got a whole lot of different diagnosis codes in that range, where before with ICD-9, we didn't have as many on that there. So this option allows you to kind of sort things out and make things a little bit better. The other nice thing about utilizing this is that you can actually add those variables into conditional logic. And this would allow you then to, again, the if and when certain things that you could associate that this information that you're using on a daily workflow that pushes down to actually pull up different triggers and information like that that's going to go ahead and pop up onto a template when needed for certain situations that are really important to remind the provider of certain things that have to be on. I use an example of the HCC coding, which is specific to the Medicare Advantage patients, that basically with them every year, if you, it's the risk associated with that, but by coding certain codes on that information that goes down, this is how Medicare budgets money to give to these Advantage plans, and that's kind of ties back into, you know, information coming back to you at the end on the provider side of it. So an example here would be that I would have the CE and then the insurance type is why I called it a drop-down, and the drop-down list could be information that goes onto that. And so basically you could have it at the beginning of a template. When they opened it up, they would choose that information, what kind of insurance type it was. It would push down there, and then you've got this variable to be able to use on it, and then this would be a diagnosis associated with that patient. Obviously they could have hypertension, they could have everything that you're tracking on that could all be yes, and then you've got a way to go ahead and sort those out. But at a high view, this is kind of what I've used on here. And then by setting up some logic down here, I more or less said, you know, if the patient if the clinical element, if there's a yes for diabetes and there's a yes that the patient's a Medicare Advantage patient, then I want it to go ahead and populate and give me different options on basically codes. And so these codes would be the codes with the HCC coding that need to be reported ongoing back into the Advantage plan so that it ties back into that risk. And so this is what this would look like on the template, is basically when you open up the template, this would come onto it. And as they change, I mean, that basically maybe I was a Medicare Advantage patient now, but then once, you know, the time rolls around and I decide to go back to straight Medicare again, the clinical element looks at the most latest variable in there. So if I change to Medicare the next time, this particular patient would now become a Medicare patient versus a Medicare Advantage patient. So it's an ongoing change on that to be able to utilize it, but it'd be very effective to be able to help manage that information that goes through. And so this is the information, and then it would just pull up my specific diagnosis code that I needed for that. And if you're not familiar with HCC coding, there's areas where there's certain codes that they have to bill with, and then they get points for that. It adds up to a dollar amount, more basically in points, that gets turned back in, and that's how it falls back into it. But it's pretty effective to be able to use that and manage it from the record side of it to push on all the way over to billing. And as I said down below, again, in situations like this would be a good candidate for utilizing those .mp 2 through 6 codes to be able to push and pull, and then they could bring data back in there and update life cycles and so forth on that. So with version 11, a lot of you may be using or may not be using, but in the situation I just explained to you, and I'm just using these as an example, this would be a good place to use the push label information that goes through. So if it's on the template, you could push it right down. You know, again, you'd want to train whoever's using these to make them understand what they have to do. But if I were to enter this data in starting today and I had never been able to use it, by utilizing the push, this would allow you to start getting data back down into that clinical element sooner. The other thing about utilizing this option is that then by the time you get down to the assessment level, if you have that information into quick text, they'd open up the quick text, it's going to recognize the logic and this information that's there and pull to give you the right information into it as it goes on. So these are very effective when it comes to utilizing it in the concept of being able to, at the top of the note, I have data that I want it to go somewhere else in the tab, but yet by the time I get to the bottom of the note, I want to be able to pull that data back out into my note. And I can do that very effectively by using quick text and then these push labels right here. The other option are those label codes that we have, and this is just an example of the clinical elements. This would be the concept that you use it, and this name population would be the clinical element template that I am putting data into for me to pull data back out of. So in this particular case, this is my population, and I've got information that is my Medicare Advantage and my DM. So if you didn't want to use the dot codes that we have up here, but you still wanted to utilize the data, the interlabel code would be an option that you could use. By clicking on that in the note, you could open up and populate the information you wanted. Click OK, and then it's going to go ahead and populate on the note. But then the variables of the checkboxes is what I used in here, which equals Y for yes, would be documented in it already. And then it's going to be there for them as they move on. So you do have a couple of different options that you could use on this. And this dot information could pull from a nurse's note down to clinical elements as well, so that if that's the workflow you have and those get opened up first before a provider goes in and opens up his template, all this documentation could be pushed down there already. So by the time that other note gets opened up, it would already be there and you wouldn't have to worry about having any of this on the physician note at all. All right, guidance is just information here that I used for this presentation, just different information that I had, information that pulled onto it that you can reflect, and this is the link to the code changes. And our next Lunch and Learn session is scheduled for October 12th, and this is where we're going to start going into, we're going to talk about that menu objective 10, the public health. And then I'm going to start going through the CQM reporting and reporting tools, use triggers. I know we're getting right into that season of testing as it is, but by understanding what report settings and everything else and the use of different triggers, which we even talked about in this session, and being able to utilize this data, we'll be able to help as you're starting to go through that process to attest, and then maybe using some of these tools to make it easier as things come on and helping you through the whole attestation period towards the end of the quarter if this is what you're doing, and instead of waiting till the very end and not understanding why certain things are not reading as they will. All right, it looks like we are right at the 15-minute mark, and we can go ahead and take some questions and answers here and have time to that, and then there's the contact information if it's something that you'd like to contact outside of anything we don't get answered today.
Great. Susie, if we could go back to slide 21, Ryan wanted you to just go over that slide again, if real quick, if you can do that.
21, this right here?
Yeah. Mm-hmm.
Okay. So with this one, let me go back one page. So this is the logic that I used, information that pulls in so that it's looking at the structural data that is pulled into it. And so on this, in this one, what I'm saying here is that in order for me to get this result here, I pulled it from the lab results in the documentation. And so you can see that it says kidney disease stage 2 mild. I'm going to flip back one. And you can see that my lab, go back, where's my lab? I think I might have copied that one. We go to this, here we go, to the lab. So I ended up getting my result here with my chronic kidney disease stage 2. And how I was able to get that result was that my logic in here says that the lab test of the GFR is greater than or equal to 60, or it's going to be less than 90. And that's the range that is used to be able, the guidelines to be able to come to this diagnosis code of the stage 2 mild would be this lab test. And so what I'm saying in this example right here is that I pulled this from the lab results in the documentation. So you would have that logic in there, and then you'd have to make sure that whatever result you had in here, the diagnosis code, if this is what you're pulling from the labs, is that those labs, what those ranges are in the labs is associated to the logic. Down in this one here for the nicotine dependence is I just pulled that right from the smoking vital name, and then the result that was in the smoking. So you've got your current smoking, which is all I used on there, but you could do current smoking, heavy smoker, information that goes on to that is where I pulled that information to be able to bring this particular result back in that I wanted to be able to do with the nicotine dependence on that. The persistent asthma is the same thing. I'm going to go back to one here. Right down in here with my asthma is you've got the first one with persistent asthma is I just looked at, I had my clinical element with a result of that is greater than or equal to 60 because that is the guidelines where that would be the result of your PFT test that comes back in that says it's going at a 60%, and so that's the guidelines they use that would go ahead and classify it as being severe asthma. Now, if it was, as you look down below here, I had a severe asthma with the status of asthmaticus, which means that the patient is in pretty dire need, but it has to be severe asthma, so my test result would be like is greater than 60%. But then with that, usually what defines that diagnosis would be the pulse rate for that day, how many times my heart is beating, and then you can also add extra information on that as well, which would be you can do your pulse ox because there's a limit of pulse ox. It's going to be abnormally low, and then your respiratories is also could also come into that whole involvement in there, and that you could bring all of those values in there to be able to document, to be able to bring in the information as well. This one, it looks like I have my pulse right in here as a 123, which the average on that would be like what at 120. So if the average was 120 or greater, then it would go ahead and pull that into that as well. I use 123 as an example, but usually what they would look at is a 120. That's why I'm saying if you're going to build these, make sure you talk to your provider as to what they see information and how they would classify that information that goes on to make sure that you have it in there. But for this one, you could even bring, I've only got two variables in there, but you could bring in your pulse ox and you could bring in your respiratories as well from the vital window that could help come to this conclusion as well. There's other elements involved which might just fall from the review of systems and how the patient is presenting that is not in the form of structured data. There's nothing stopping you from creating the template and putting it in there so that you could come to that conclusion. But a lot of times this is really comes from, that vital window and what it is that they're testing out that would define that particular diagnosis versus just having severe asthma as above. So that's really what I'm explaining when I come back into this, is where I'm pulling this from and the information that came to this result here. Is that, does that explain that better, or?
Yes, thank you.
Mm-hmm.
And then I guess a quick question for Nina, who's on the line. Nina, I know you've been answering a lot of these questions as they've been coming in. Is there anything that we want to address with the group or have Susie answer now, or are these all more follow-up questions?
Yeah, I do have some questions, and it probably would benefit all of them. Susie, I had a question that said, how many of the 1943 new ICD-10 codes will impact family medicine providers?
It would just depend on if you're going to use them. I think when I've looked on, kind of going over there, I'm seeing that there's a lot down to like some wound care, different things on that. But I think what you really would want to do again with anything is go into that link that I've got onto this presentation and go through the codes and see if this is something that you use ongoing. The very first one starts at abnormal results, which probably are some things that you guys use on that information that goes through. But it's kind of across the board. So I guess the answer would be the best is to go back and look at them. I don't going to say it's not going to be all 1,400 of them, but there will be some changes that you probably use on there that you should go back in and look at it. And understanding really what I've seen overall is if they were fourth-digit codes, this is what you've been using. Now it's important to understand that they're going to go to fifth-digit codes. And if there was, LCDs haven't changed that I can see on anything, but you would want to make sure that if you've got anything hard-coded in your notes, like in quick text or anything like that, using that, if any of those change, those are what you want to get updated so that they go through, when they go to search on HLI, it would go ahead and come up and should come up with the fifth digit to be able to push down to billing.
Okay, the next question I have is, with the revised codes, the news codes, will we have to manually change current diagnosis codes, or will they be revised ones automatically changed to the current new correct codes?
If you are talking about, I mean, with the revised codes, they would update in the diagnosis table according to the description information you have. So you shouldn't have to do anything on that as far as like if a description possibly has changed on that. And if the revised code was a certain code one way and now it's a new code, it's by utilizing the HLI system, it should go ahead and update that. So I don't see off the top of my head that you'd have to change anything that would be reflecting from the HLI down to the diagnosis table. It should just go ahead and as you use it, push down into it, and if it doesn't exist and that description would not, then it would go ahead and update that.
Okay, and one more question for this one. Can the triggers be set up per provider, or will it impact the entire group of providers?
If you didn't want it to, I mean, if you want it specific to providers, then I would do, you know, in your clinical element name, then you would do, you know, like the .ce:\, and, you know, K for Dr. K, DM, if this is how you wanted to separate it out, because it's going to be a further separation on that. You would have the ability, if you were going to pull something out of the triggers, like if you're going to use a patient inquiry, you could always, you know, you could pull by clinical element, and then you can narrow that down by provider as well. Or if you were, you know, going to utilize the next step to be able to push it down, like say into a registry, then you could sort it out as well at that level. So you could get it, I guess, as specific as you want it or not. It just would depend on how you plan on pulling that information back out of it. And if you want to do it by provider, then you may want to, you know, associate it to the clinical element. Could be anything that it needs to be, because once you pull it down to that, that's where it's going to be associated to it as it goes through. So I'm hoping I answered that right, or if that's the reason why you'd want to break it out by provider. If you leave it generic, it's going to be generic, but you would have the ability to like run a patient inquiry report by that code, and then you can narrow it down by provider another step beyond that.
I think that's probably all we have since we're at the top of the hour. Allison, I do have a couple of more, but I do have their email addresses, and I will send them to Susie, and she can get the answers back to everyone.
Excellent, great. Thank you so much. And yet we are at the top of the hour, so I want to thank all the attendees for joining us and spending time over the last hour learning about this important topic. And I want to thank Susie and Nina for answering our questions and giving us the presentation. We hope that everybody has a great day, and we look forward to seeing you on the next session. Thank you.
Thank you.